Honorable Chairperson, Dr. Shuttam Kumar Vishwas Sir, Associate Professor of Surgery, Co-Chairperson, Dr. Taufiqul Haq Sir, Associate Professor and Head of the Department of Surgery, Resource Person, Professor Dr. A.S.M. Lukman Hussain Choudhury Sir, Professor of Pediatric Surgery, my respected teachers, senior and junior colleague, and learned audience. Assalamu alaikum. I, Dr. Mohammad Murshiduzzaman Russell, Intro Medical Officer, Department of Surgery, welcome all of you to this clinical meeting on a 20 years old man with acute abdomen. The speaker of this clinical meeting is Dr. Tanvir Hassan, IMO, Department of Surgery. Now I request Chairperson, Co-Chairperson and Resource Person, please come to the dais and conduct rest of the session.
Well, sir, Director sir, and professors present here, and my colleagues and my intern doctors. This
Honorable Chairperson, Honorable Co-Chairperson, Honorable Resource Person, my respected teachers, my dear colleagues, and learned audience. Assalamu alaikum. I am Dr. Tanvir Hassan, Intro Medical Officer of Department of Surgery. And with the permission of the Chairperson, I will like to present my case on clinical meeting on a 20 years old man with acute abdomen. At first, the particulars of the patient. The name of the patient is Tushar Chandra Burman. He is a 20 years old Hindu unmarried male, and he is a student hailing from Bormi, Sripur. He was admitted in this hospital on 19 July of 2023 at 7 p.m. and he was examined on the same day at 7:30 p.m. Presenting complaint. He was presented with pain in the upper abdomen for 12 hours and vomiting for 4 times for the same duration. History of present illness. According to the statement of the patient, he was reasonably well 12 hours back. Then he developed sudden severe upper abdominal pain, which was colicky in nature. It radiated towards the umbilicus and it became generalized afterwards. The pain was aggravated by moving and slightly relieved by lying flat. And it wasn't relieved on taking analgesic. The pain was not associated with fever or jaundice. He also gave history of vomiting for 4 times after the onset of the pain. Vomitus was bilious and non-projectile in nature, sour in taste, and mixed with gastric contents. His bladder habit was normal. There was no history of hematemesis, melena, and hemoptysis. History of past illness. He has no relevant past surgical and medical history. Personal history. He is a non-smoker and non-alcoholic person. Family history. His family members were not suffering from such type of disease. Drug history. He gave history of taking anti-ulcerants occasionally, which was not prescribed by any registered physician. He was completely immunized as per as EPI schedule. He belongs to lower middle class family. Now physical examination. On general examination, the patient appears ill-looking. His height was 5 feet 6 inches and weighed 62 kilograms. His body build was average. He was well nourished and well cooperative. His decubitus was on lying flat. The patient was mildly dehydrated and anemia, jaundice, cyanosis, clubbing, koilonychia, leukonychia, and edema all were absent at the time of examination. His pulse were 94 beats per minute. Blood pressure was 110 by 70 millimeter of mercury. Respiratory rate was 22 breaths per minute. Temperature was 98 degree Fahrenheit. There were no palpable lymph node. Neck vein was not engorged and thyroid gland was not enlarged. Now, systemic examination. On inspection, the abdomen was distended uniformly and restricted during respiration. There was no visible swelling, lump, pigmentation, visible peristalsis, scar mark, and engorged veins. On palpation, abdomen was tense and tenderness was present all over the abdomen with maximal tenderness over the right iliac fossa. Abdomen was rigid, local temperature was not raised. There was no organomegaly found on deep palpation. On percussion, the percussion note was dull and upper border of the liver dullness was present at the right sixth intercostal space along the mid-clavicular line. Bowel sound was absent on auscultation. On digital rectal examination, there were no perianal swelling, skin tag, fistula, hemorrhoid, or any excoriation in inspection. And on palpation, anal grip was intact, prostate appeared normal, and rectum was empty. On examination of other systems, revealed no abnormalities. Now, salient features. Mr. Tushar Chandra Bormon, a 20 years old male hailing from Bormi, Sripur, was admitted into this hospital on 19 July of 2023 with a complaint of sudden severe colicky abdominal pain for 12 hours. The pain initiating in the epigastric region was radiated towards the umbilicus and became generalized afterwards. The pain was aggravated by moving and slightly relieved by lying flat and wasn't relieved on taking analgesics. The pain was not associated with fever and jaundice. He also gave history of vomiting for 4 times after the onset of the pain. Vomitus was bilious and non-projectile in nature, sour in taste and mixed with gastric contents. His bladder habit was normal. He had no history of hematemesis, melena, or hemoptysis. He was non-anemic, non-icteric, and normotensive. There were no past surgical and medical condition or any other comorbidities like diabetes mellitus and tuberculosis for now. Per-abdominal examinations revealed uniformly distended abdomen and the movement was restricted during respiration. Tenderness present all over the abdomen with maximum tenderness over the right iliac fossa. Percussion node of the abdomen was dull and upper part of the liver dullness was present at the right sixth intercostal space along the mid-clavicular line. Bowel sound was absent and other systemic examinations revealed no abnormalities. Now, what may be the diagnosis?
I'm not saying anything. I think
The provisional diagnosis, perforation of gas-containing hollow viscus. These are the differential diagnoses. Acute appendicitis, acute intestinal obstruction, acute cholecystitis, and acute pancreatitis. These investigations were done after the admission of the patient. On 19 July of 2023, random blood sugar was 4.7 millimole per liter, serum creatinine was 0.7 milligram per deciliter, and serum electrolytes was sodium was 146.5 millimole per liter, potassium was 3.89 millimole per liter, and chloride was 107.5 millimole per liter. Complete blood count shows hemoglobin percentage was 14 gram per deciliter. ESR was 3 millimeter raised in the first hour. WBC count was 12,200 per cubic millimeter of blood, and platelet count was 3,11,000 per cubic millimeter of blood. Plain X-ray of abdomen and plain X-ray of chest. Both shows free air shadow present under the both domes of diaphragm. And this was the picture of the X-ray, which shows presenting gas shadow under the right dome of diaphragm and also under the left dome of diaphragm. Right dome of the presenting gas shadow. Yes. On 23rd of July 2023, serum electrolytes was repeated and sodium potassium chloride all appears normal. Preoperative management. On admission, the patient was resuscitated by these procedures. Operation note. As the patient was diagnosed as a perforation of the gas containing hollow viscus, so we decided to perform surgery, to perform laparotomy on this patient. On 20 July 2023 at 9:45 a.m., operation was done. Indication of the operation was perforation of gas containing hollow viscus, and the name of the operation was laparotomy followed by thoroughperitoneal toileting under general anesthesia. These were the peroperative findings. There was a diverticular structure 40 cm proximal to the ileocecal junction. It was 5 to 6 cm in length and 3 to 4 cm in width. Wall of the structure was thick and the base was edematous and inflamed. The base arose from the anti-mesenteric border of the ileum. A perforation was found on the base of this diverticulum. Omental adhesions were found at the site of perforation which seal the perforation itself. Moderate amount of greenish collections were found in abdominal cavity with some extent of slough. And this is the picture which showing a perforation at the base of the diverticular structure. The procedure of operation. With all aseptic precautions, abdomen was opened by upper midline incision. No abnormalities were found after searching for perforation in the stomach and the first part of the duodenum. Then small intestine was searched in the same manner. Then it was found that there was a diverticular structure 40 cm proximal to the ileocecal junction. It was 5 to 6 cm in length and 3 to 4 cm in width. Wall of the structure was thick and the base was edematous and inflamed. The base arose from the anti-mesenteric border of the ileum. A perforation was found on the base of this diverticulum. Omental adhesions were found at the site of perforation which seal the perforation itself. Moderate amount of greenish collection was found in the abdominal cavity with some extent of slough. Then resection and ileo-ileal anastomosis was done by Vicryl 30 round body. After thorough peritoneal toileting and proper hemostasis, a drain was kept in situ. Abdomen was closed in layers with proline number 1. Lastly, resected specimen was sent for histopathological examination. And this is the picture just after the ileo-ileal anastomosis. And there is also a drain tube which is seen, which was kept in situ during this procedure. And this was the post-operative management of this patient. The post-operative period of this patient was uneventful, and on the third day, the check dressing was done, and on the fifth day, the drain tube which was kept in situ was removed, and on the 10th day, all of the stitches were removed, and he was discharged with proper treatment from this hospital on 31st of July of 2023. On discharge, he was advised to avoid heavy work for 3 months. Eat soft diet for 15 days. and use abdominal binder for 3 months. He was also advised to come for follow-up after 1 month with a histopathology report. And this was the histopathology report which was provided by our histopathology department. Specimen, resected part of the intestine. Macroscopic examination. Specimens consists of an irregular firm tissue measuring 3 by 2 by 0.2 centimeter. Cut section show foci of dark brownish areas with friable surface within the normal looking intestinal wall. No perforation is seen. 2 blocks were embedded. Microscopic examination. Sections show wall of small intestine. It reveals edema and good number of mixed, both acute and chronic, inflammatory infiltrates throughout the wall. No ectopic tissue was identified. Neither granuloma nor malignancy is seen. The diagnoses which are provided by our histopathologist were resected part of small intestine, acute or chronic inflammatory lesion of the small gut, may be a case of Meckel's diverticulum, which should be correlated clinically. And this was the scanned copy of our histopathology report of this patient. Confirmatory diagnosis: perforation of Meckel's diverticulum. And these are the pictures of the patient during his follow-up visit. These pictures was obviously taken and included in this presentation with the permission of the patient. Last but not the least, I'd like to mention the name of two persons. One is Fabricius Hildenus, who was a German surgeon, and he was often mentioned as the father of German surgery. And he was the first person to find out about this Meckel's diverticulum in the 16th century. And another person is Johann Friedrich Meckel. And Meckel's diverticulum is named after him because he was the first person to explain the embryological origin of the Meckel's diverticulum. And at that time, on 16th century, there were many less surgical facilities. Still, they identified these rare cases with the dedication and thirst for knowledge. And that's why I'd like to pay tribute to them on presenting the case of the base of the perforation of the Meckel's diverticulum. And with this, I'd like to conclude my presentation. Thank you all for having me and having patience, interest, and attention. Thank you all.
Now the floor is open.
perforated surgery are coming up with a normal symptoms but abnormal diagnosis. Anyway, it was very interesting. Obviously, we learned something new as well. Thank you very much to Dr. Tanvir for presenting the presentation, and he presented very nicely. And slide preparations were also quite good.
Thanks to our resource person, co-chairperson, to helping me, and my departmental another যারা আছে আমাদেরকে তানভীরকে হেল্প করছে এবং তানভীরকে ধন্যবাদ যে সে সুন্দর মতো প্রেজেন্ট করছে। এটা স্লাইডটা খুব ভালো ছিল। আর থ্যাঙ্কস টু অডিয়েন্স টু পেশেন্স হিয়ারিং।